go. It's not behaving. Oh, there it is. This is what I was always. This is what happened last time. I said it before, and as far as I'm aware, it may well be that it's now live. And here I am chunnering.
It says it's live on mine.
So smooth as ever. But as far as I'm aware, we're now live. Let me make sure I press record as well. If any of you guys can just check that as well.
Yeah, it says it's recording and it's live.
Yeah.
It is. Lovely. Well, thank you to those that are joining us, as well as thank you to our panel here, let's call it that. I'm Jack Chew from Physio Matters, quite used to leading discussions, rarely as important and as nitty-gritty as this one, I'll admit, usually on something simple like a clinical condition or broader, sometimes broadly more policy discussions. But this one's more of a sort of our musings really on all things sort of MSK, private practice particularly, but MSK practice and when it creaks back into gear, especially for face-to-face consultations, but also what is the brave new world going to be for us moving forward? And we've all got lots of thoughts on this. The backdrop really is that I was kindly invited to contribute as a sort of very arm's length administrator to a COVID-19 support group on Facebook by my friend Jemma Oliver, who set this up very early in the process by recognising, and she'll tell a lot more about this, but recognising that was something that would be of utility in her opinion, and she was certainly right, and it's been very active and very helpful for many people. And so we want to see if that can then move forward into trying to provoke a solution-based discussion as well. And so we're joined today by a number of people contributing to that group on a regular basis and to give our thoughts on it. But before we get into that, Jemma, I want to just bring you in, if you can set the scene a little bit on why you set that group up and on what you hope it can do then for the future.
Yeah, I think I've mentioned, and if you've been a member of the group, that, the way that people have taken it on board and engaged has been amazing, and it is only as strong as your contributors, and so it's really, really nice, and we're getting up to now 700 members, which is phenomenal. And I think a lot of the messages that I had, that people are finding it very useful. I set it up pretty much as we were all very unsure about what was happening, and a couple of colleagues and friends were having chats on Facebook about what was happening, and there was lots of discussions happening in different places on social media. And I thought, I'm lucky, I'm actually not working clinically in private practice face to face at the moment, but these conversations were happening, they needed to happen in the same place. So I thought, well, let's set something up for friends. I'll hold my hands up and say it was just an idea for friends to start with, to see if we could just join a group for everyone to put the resources down and see where we got to. And actually it pretty much went from there. And I think as things have evolved, you've seen a difference in the themes and the chats and the things that people have found quite passionate to talk about, whether that be obviously making the at the start and making the decision to go into lockdown, through the various changes and obviously keeping morale going, right through now into obviously the critical time I think that we're in, where the decision and making and the risk and assessing what we need to do now to reopen is at the forefront of everyone's minds. And I am really pleased that people have engaged and taken it on board, because I think there's lots of different groups out there, but I think for me the main reason that I wanted to start this is that it's a discussion forum, it's a support network, it's a group, I don't want to use the word safe space, but that is essentially what I would like it to be. And I would like to keep this moving forward after the pandemic, and actually see if we can create an environment for discussion. There's a few things and themes that have been highlighted so far in the past 6 weeks that actually will continue to evolve as we move forward. So it'd be nice to remold this and keep working together to support this in various forms. So that is why it's set up, and that's where we are.
Yeah, no, that makes a lot of sense. I think it's going to be a long time until we're out of the woods on this in various different ways, and so it's certainly not going to be something that's going to be not failing to serve a purpose anytime soon. So no, thank you for sorting it out. Thanks for setting it up, and also thanks for what potentially might be a next chapter of moving towards some solutions. There's such a huge range of opinion within the professions, the MSK professions on this, and everything, a huge spectrum and everything in between, which we want to try and make sure we cover. Not necessarily all of us holding those opinions, but certainly we want to be making sure that those of you in the comments section. Also, we will have the facility for those of you that might want to get involved and join us on the stream. We'll be posting on the comments how you can do that. If you jumped in without an invite, then or without letting us know, then certainly you'll be left in the waiting room disappointed. But if you've got something to say and you want to then share that and you want to jump on the stream with us, then please do, especially from the support group. And if you've been active in that, then Jemma will be helping us to moderate that, as she's been doing so brilliantly. But without further ado, I want to make sure we bring on our panel. We'll do a round of introductions. First and foremost, Jonathon Bell, if you'd like to introduce yourself to the viewers.
Hello, everyone. I'm afraid I'm the orthopedic surgeon here, which but I've run a clinic for now 20 odd years, Wimbledon clinics, and we've been through a lot of ups and downs, and I've learned a lot about what it takes to make decisions as a small business owner. And I'm sure a lot of you on the call are in a similar situation. And I think that we have to plough our own furrow here, as we'll get into more depth on that later in the call. But that's me. I'm an orthopedic surgeon. I do knees and I run a business.
Lovely. Geoff, twinning, we want to bring you in, especially because I know you do need to dart off at some point on the stream, so we want to get your opinions out there. And some news that you have for us as well. But Geoff, introduce yourself if you would, first and foremost.
Yeah, thanks, Jack. My name is Geoff Twinning. I'm 15 years now private practice, elite sport background as well, and I contract out to a various number of other organisations at the moment as well. I suppose the big thing for me is I run a relatively large, can you say that, large small business, but a large physio clinic in Gloucestershire. And again, like most of you, the issue is about, when is right to reopen? How do you interpret the guidance rather than the instruction from our governing bodies, and comparing that with our fellow colleagues around the country, really, and how that may differ from region to region based on how it's been affected by COVID-19.
Oh, fantastic. Yeah, great to have you on, Geoff. Paula Clayton, you've been contributing to the group and have had plenty to say, all of it thoughtful. So thanks for joining us. Would you like to introduce yourself?
Sure, I'm Paula. I have got 25 years experience in elite sport. Previously was a soft tissue therapist, now a sports physio, and I've got 2 private practices that are sports injury clinics, and I also work for a private hospital running their sports injury clinics. So and yeah, obviously the 2 different things of what's happening in private practice and what's happening in the hospitals might be quite interesting to discuss today.
Yeah, fantastic. Great to get those angles. As I said, we want to try and cover as much diversity of thought on this, and the circumstances and contexts are very relevant. And last but no means least, actually, let's be honest, last but least, my mate Mike James. You guys might have seen him on many a live stream with me over the years, but of course, always a great voice on these topics, and certainly someone that's got plenty of interesting angles to share with us all. So Mike, introduce yourself to any of the listeners that might not have heard from you recently.
Thanks, Jack. Thanks, Jem. Hi, everyone. My name is Mike James. I'm a physio. I'm coming at this really with 2 hats. I have 2 day jobs. Predominantly, I am a director of Sports Injury Fix. So we are a platform for multidisciplinary MSK therapists. So from that angle, I spend a lot of my days as a sounding board and listening to the problems facing many therapists across the professions. But clinically, I have a small business called the Endurance Physio, and I exclusively work within endurance sports arenas.
Fantastic. Well, thank you all for being here. Now, just to reiterate for those that are just joining us, we will be able to try and get you guys involved. If you've got strong opinions, you post them in the comments, and you can be involved in the Zoom call. We've posted the details. We have had someone just come into the waiting room. We won't be just having that flooded with people. You may well have something to say, but what we want you to try and do is then bring that forward on the comments section and tell us that you're joining us, just to make sure that we don't then get Zoom bombed. So please do be sure to post them, and we'll try to involve you later in the discussion. So, but first lap that I want to do with you guys, we'll do a lap of comments, which will be sort of everyone's hot take on the matter. One thing that I want to make sure I set the scene on for this, in case people are tuning in, I won't want you to be under false pretenses. One thing that we won't be getting into the weeds on this live stream, and it's not because we're averse to it, certainly not on Physio Matters, is the oohs and ahs of clinical styles of practice. And they are relevant to this discussion, don't get me wrong. the ability for different clinics to adapt or not adapt into a landscape in which virtual consultations have become a thing, then fundamentally that is an interesting conversation to have, but it's not necessarily one for now, and it's not the primary thing that we want to be discussing. That would end up, in my opinion, talking about the 10-20% of things that we might disagree on, rather than the 80% in which we need to try and be unified on. And especially under the nature of this being sort of a sport group, a discussion, we want to be talking about other issues other than oohs and ahs of styles of practice and the utility of different styles of practice. So that's going to be what we're avoiding for now. I'll certainly be involved as someone that's an active and opinionated moderator. Jem's going to be leading the conversations as well, as all of us are going to be sort of thrashing ideas around. But what I want to try and do first lap, before we take any questions and get things going, is I want to go through everyone's sort of hot takes on the matter. So we'll go in the same order then. So first then, Jonathon, if you could give us what's sort of your take on not just the broader issues around the pandemic, but certainly the ones around what are the key variables, do you think, that influence our thoughts around how and when we might reopen for face-to-face care?
Yeah, I mean, I think that we'll start off with perhaps the first point that I think is troubling people is that there seems to be a vacuum of assistance, advice, and detailed information that's personal to your own needs as a practice owner. And I think we've got to get ourselves over that, because it's not going to happen. And it's certainly not going to happen in a timely fashion. You know, experts rely on telling us everything that's happened in the past. You know, without wishing to offend the academics, they're one randomized controlled trial behind the curve in something that's evolving so fast. So I don't think we can necessarily turn to those sort of people to get advice from them. I think the other thing is that as small business owners, we are much more nimble than big corporates, and we don't have risk management departments, nor do we wish to have risk management departments, because at the end of the day, if you're running your own business, you are by definition a risk taker. And we've just got to stand up and make an assessment of the risk and go for it. I don't think anyone in 18 months or a year or 6 months' time can turn around and say to any of us as practice owners that if we gave this serious thought and we put in place measures to allow us to open, I don't think anyone can turn around and say, you did wrong, you know, that wasn't appropriate, because actually everything about this pandemic is new. We can't draw on other pandemics to understand, you know, whether we wear gloves or whatever. So as long as we're putting in common sense measures, I don't think it really matters. What I do think helps is to have a group like this. I run 2 groups with local physio practices, and we work with the owners, and we're coming to a consensus view on what we think will be a good way of opening. Not because we feel we've got to bash out the best way or the right way, but if we agree on it, and we've got 20 of us agreeing on it, we're probably not going to be too far off the mark. So I think we have to accept that we're not going to get the help we would dearly like, and I think we've just got to get on with it. The biggest issue is going to be the fear of flying. Nobody is going to get on an airplane in the next 3 months unless they have to. And no patient is going to come through our door unless they feel safe. And that is the issue that really has to be addressed. And I think if you address that as best you can, you'll probably have covered all of these issues about gloves and aprons anyway.
That's an interesting one, especially that in and around safety and public confidence.
Yeah.
There's going to be a gap between what we think in terms of what we perceive medically as being the provisions that are required, and there might be a gap between what then the public would want us to be doing. So it's interesting for us to work that out, isn't it?
So the messaging is, we can only get people's confidence through their messaging, and the messaging has to be really strong. And that may mean that we're probably going to have tighter measures than the hospital within which we work. Why? Because we believe that that's what's required to get the patients to come through the door.
Sure. Right, we're going to go Jemma, then Geoff, actually, because I'd like your thoughts on this, Jemma, because that's one of the things that you've had your finger really close to the pulse on, is what the people in the group have been crying out for is some sort of crisp guidance, roadmap, something that's quite overt, but for various different reasons. Bodies such as the CSP and Physio First, especially in the early days of it, were trying to seek. They weren't in a position where legally they could suggest the overt closing of practices because of the fact that there's ambiguity from the government. It falls through the cracks, as we sort of mentioned earlier. And so what has been the key thing that people have been crying out for? And also, please do take the opportunity to give your sort of hot take as well, if it doesn't cover that topic.
Yeah, I think, first of all, I just want to say that I think the whole concept of obviously doing this, I think we've had a number of discussions between ourselves this week when we decided to set it up as, is the time right to do this? Do we have this conversation, the day before the Prime Minister gives some sort of announcement on maybe how we're sort of easing out of lockdown? My take on that was yes, because, from moderating the group and looking at the general themes that are coming out of the group, people are frustrated. I think that's quite clear over the past few days, and quite rightly so. I think in some circumstances people are feeling unsupported. People are reading the information that's coming across, and it is there, I think, in some forms, whether you're looking at the CSP or whatever body you look to for that sort of reassurance, but it's not coming through. And the general feeling from the group that I'm moderating at the moment is that people don't feel supported, and especially the private practice group, they don't feel like their voice is being heard, whether that be from starting at the beginning of lockdown and actually easing into what they were supposed to do, and then right through the process, and now they don't feel like they're getting enough information. I think one of the things I want to say is that the aim and the reason we decided to do this today was I want to give reassurance. I want to try and help build confidence in people that are going to have to make difficult decisions, and you are going to have to make difficult decisions potentially in the next few weeks and months, and I want to maybe hopefully get across that I would love all the answers to be given next week and from tomorrow. I'd love us to get a lovely green light and a beautiful pathway from the CSP or whoever you look to. I just don't think that's going to happen to be quite as clear and in all the ways that we want. So I think I wanted to do this today to maybe manage expectation, maybe get you to think about things slightly differently, maybe get you to sort of think about how you would like your practice to look moving forward, like Jonathan's sort of said, and how are you going to get that message across? And actually, as we'll come on to, what are the decisions that you personally want to make? Because as I've said on the group chat a lot, in this week, is every situation is different, and it's impossible for us to judge everybody's clinical environment against our own because everybody's different. So we can give guidance and takes on different thought processes, and hopefully that's what you'll get from today. I'm in a lucky position, it doesn't affect me directly, and so that's why I think it's nice that I am continuing to moderate the group, because I'm in a different environment where I'm triaging remotely, and I don't work in a face-to-face environment at the moment. So, I'm lucky in a way, but I can see both sides of a discussion. So yeah, that's me. And
having had a diverse background of experience as well, Jemma, you're going to be able to have empathised across different sectors and circumstances. So that's been really helpful for us to have that. You've still got your, as I said, finger on the pulse, which has been brilliant. Now, that's a really good overview of the circumstances that we find ourselves in, where people, if you're craving a green light, you're going to be waiting a while because we never got a red light. That's where we end up in this circumstance, where fundamentally, and it's become increasingly clear over the last, I'd say, 4 to 6 weeks, that the government and the government's lawyers, quite rightly in many ways, do not want to engage in the question of what do they mean by urgent care. They want to put that to medical professionals, and somewhat rightly so, but that does mean there's massive ambiguity because, of course, those aren't well-defined terms across different, especially within different styles, not just styles of practice, but different professions and all that sort of stuff. So it ends up being up to us to try and work out the U's and R's. And on this group, we don't know what's going to get said tomorrow, but we can sort of try and think, and we'll be interested in your thoughts on the comments as well, as to what you feel are the permutations. What would influence your decision? What other industries? Because they're not going to turn up. Boris Johnson's not going to sit there tomorrow and say, MSK private practices. This is for you. This one's for you. Maybe not this week, but next week. They're just not going to come. So let's be serious about it. We need to start working out the balance of things. So on that, I want to bring in Geoff Twinning. Geoff, really keen to hear your thoughts on broadly your take on the matter, but also I'm sure you're going to be willing to tell us a little bit about what provisions you're putting in place and what your plan is, pending tomorrow.
Yeah, I think I fully agree with Jonathan that there is no black, there is no white. I think from a point of closure, we we don't have to close. That's the first point. So then in the view of when do you open, it's purely going to be an autonomous decision. You know, if you look at the small print on what the CSP have given out, it is only guidance. You know, there is no law bound to it. There is no, you have to do this. It's all guidance to try and help the situation. And I think, you know, even from tomorrow, I don't think Boris's speech tomorrow will make any change to where we are today, if I'm honest. You know, he's not going to suddenly say, oh yes, you can go and hug people and kiss people, in which case the under 2 meter rule is not going to change either. So I think what we need to do now, well, this is the way I'm looking at it, is we need to plan now to, you know, when do we feel comfortable to open? Because like I say, whether that is tomorrow or in a month, I don't think there's going to be too much change in our populative procedures within that time scale. Now, you know, we've got relatively high overheads for our clinic. You know, we're looking at 4 or 5 figures a month. And at some point, we have to bear that in mind as well as client care. You know, we're never going to put someone at risk or, you know, expose risk more than what you can. But there are more factors than just the patients that we've got. We've got the financial stresses. We've got, okay, if you don't open in 2 weeks and your business is going to fold, what do you do? You know, and you've worked 10 years to build that business and your house is linked to that business. You know, there are so many factors. I'm quite lucky, I think, because we're in a region of the lowest risk in the whole country, being in the southwest. So that has a bearing compared to if you're in London. So, you know, as our clinic, we're planning on whether that's tomorrow, the next week. We've already planned, if we open, what we've got in place. So we've gone through the clinic. We have an entrance protocol. We have a protocol on booking, asking screening questions about health within the, and we've gone beyond 2 weeks. So we've said in the last 4 weeks, because we want to actually make sure that we go that little bit above and beyond what you could go, just to safeguard ourselves and our clients. So we have an entry policy. We have, when they come into the clinic, we re-emphasize some of the questions we've asked. We provide them with PPE. And for clients, it will be a mask. They'll be sanitized, so they have a strict process that they have to go through. If they don't go through it, they won't be allowed in the clinic. They'll only be able to be accompanied if they're a minor, or maybe they've got mobility issues. Other than that, anyone else who would normally attend will ask to kindly wait outside or in their car. And then once they come into the clinic, luckily we have quite a big foyer area, so we can literally do a one-way cycle. They come in, they sit. I mean, we've probably got almost 5 meters gap between seats, which is great. They go into their treatment room, they exit. The physio will book them again. So the only thing they have to do with our reception team, which again is screened, they have PPE, they stand 2 meters from the screen, is they just have to pay. And then they're straight out the door. Maximum of 2 patients at any one time in the waiting room. And we've staggered our patients, so we can have 3 clinics running at any one time, and they're 15 minutes. So we've looked at the whole process. I think we're going to dry run that tomorrow just to problem solve it, and again tick the boxes from our point of view. So if and when we do open, you know, we've looked at it as in depth as we can. You know, the questions that are still and probably won't ever be answered are the what if scenarios. So if someone said they got COVID from us, very unlikely that you could prove it, you know, because of the incubation time. It could be they've caught it off of anybody. So that is an argument I think is very slim, rightly or wrongly. All of our therapists will have full PPE. So, you know, we are going visor, mask, apron, gloves, again, not to unturned any stone. And then from an insurance point of view, we've contacted insurers. They're happy. You know, again, as most people say, you haven't been asked to shut, so why ask to open again? But we've raised the question about protection, and again, they've said as long as you've got adequate measures in place, they are happy. So the only real, I think, sticking ground for us is the guidance, and the guidance from just what the CSP have put out, which is now, what are we now, 2.5 weeks old. So whether, again, that guidance will change, I don't think it will. So again, I think that's where clinicians, we have to make that decision, right? All of the factors in a bowl. If that's not going to change in a month, we have to be autonomous, and we have to say, right, can we provide the service that we've built up, and can we do it within, you know, the confines of our walls and the safety that we can and give our clients. That's, for me, is the only sticking point, the guidance. And I don't think that will ever be black and white. And there will be people who throw morality at you, who throw other things at you. And I know people are open currently, and there's been conversations on Facebook. And again, I'm not one to point fingers. I would say support them. They're doing what they believe is right. So who are you to argue that based on not having the intrinsic knowledge that they have why they're open? There may be some out there doing it just for cost sake. You know, the old wealth before health likes to get thrown around. But again, it's not wealth. You're trying to keep the business. You may not even pay yourself. This is about paying your bills, let alone yourself. So there's lots of factors out there to play with. Again, I don't think there's going to be any right or wrong ones, but I'd be interested to see what other people have to input.
No, that's great. Thanks, Geoff. I really appreciate that. It's a great point as well with regards to, and something that has been unclear to some people, but there's no thing that especially those that have, let's say someone's stayed open and it's business as usual, no adaptation, no policy change, no overt and declared risk assessment, and that is something that is not illegal. It's certainly, I would argue, unethical. I haven't got a lot of time for that personally, but it's something that there's been a lot of people that have perceived that is something that is illegal, reportable to various authorities, and as far as we can tell, that's not true. I want to then go to Paula. I wonder what your take is on the matter, either passing comment on what's already come up, or what your general take is, if it's anything separate to that.
Yeah, I'm coming in it from two different sides, really. So currently at the hospital, we are seeing patients that are urgent cases, so not just follow-ups and you know, not just kind of you know, day-to-day stuff, but if somebody comes in with an urgent case or is post-surgical, then we're in full PPE, just exactly as has already been described. Private practice wise, I think that there was a very clear sign of respect from my patients, certainly, for the fact that we closed. Okay, and there's a great deal of support for when we decide to open. So I put a survey out a couple of days ago to about 1,000 patients, and you know, pretty much all of them have come back and said, because of the reputation and the relationships we've already built together, so these are just current patients, the relationship we've already built, that they would trust the fact that I would be taking the right precautions. And we are autonomous practitioners, so therefore we already know how to do that. We know what to do. We've been in hospitals when there's been C. difficile, etc., and you know, we've never been had to ask what we have to wear to go in. So it is slightly different, but it's not different in many ways. And coming back from that, I think it's not necessarily about us getting back to work. It's about their confidence coming into the clinic. So there were some of the questions I asked was, you know, what's going to stop you coming in? And quite a high majority of them were concerned about finances, because they don't know about their own work going forward. So that's going to be an issue. Some of them were just talking about the fact that they wanted to make sure that I said, would you expect somebody to wear full PPE? And almost nobody said, yes, I would expect mask. I don't think gloves are necessary because you can just wash your hands. So therefore, the fear factor was incredibly low. So it was very much around finances and the fact that as long as I made sure that it was sterile in between patients, which they knew I would, that they would be very happy to come back. And again, I've already got a list as long as my arm of people saying, as soon as you're open, get me in, kind of thing. So the fear isn't necessarily there, but they want the assurances. And fortunately, I said I can only speak about the actual patients I've got right now. They just want they're already pre-assured, if you like. They're confident that because they were already in place. So for example, if somebody came in that was because I quite often turn people away that are unwell. But if they came in and they were in a lot of pain, we would both wear masks. So they already know I do that, and already sterilize things down. So yeah, but and then when it comes to the hospital, obviously that's guided by the people that run the hospital. But you know, my concept, it's one of those, isn't it? Because if you can see patients in a hospital, why can't you see them in private practice? If you're doing the same cleaning down, you know, making sure it's sterile, etc., etc. And they also said that they would want to wait out in the car park and make sure that I staggered patients so that there was no crossover, which of course is going to happen because you have to allow time to clean everything down that anybody could have touched. So, you know, that's an interesting concept. So again, I'm not going to point any fingers at anybody either, but I can also understand the pressures that people might be feeling about being slated, if you like, for being open, and also the therapist being fearful of being open.
I agree with the point about gloves, Paul. I think the patients are going to turn up with gloves, and the first thing I want them to do is take them off, because you don't know, they've been to Sainsbury's and all over with those.
Absolutely.
Gloves. So I don't want patients wearing gloves in the clinic. And I think that also, again, back to the point of messaging, you know, there's going to be overt hand washing and sanitization between contact with patients. And I think that should be enough. And I don't think putting on gloves adds to that. And also examining patients with gloves on is more than likely going to be uncomfortable, particularly if they've got a hairy leg or
So true. Can you imagine?
Some chafing going on.
I've just got a question, if we don't mind going back to Geoff from Fiona Muir. Sorry if I didn't pronounce that right. Geoff, are your staff employed, and how are you managing them coming off furlough, if so?
All of our admin team are furloughed. Our practice manager is now off furlough and has been for the last week. Just because recent relocation, we've still got a fair bit of stuff to do. So we've utilised the last week to change a diary and, again, make sure that together we're putting all these protocols in place. We've got a full risk assessment report that we've done and printed out. So again, we've got a file that we can go to and all of our staff can go to, so that everyone is happy and they've agreed to the process that we've got in place. All of our therapists are contractors, so they can obviously claim the self-employment benefit that's out there. Myself and my business partner are directors of limited companies, so we've actually not been able to claim anything, which again, these are other factors to influence. You know, we can't claim other than furloughing ourselves, which when we've still got a business to try and run administratively, we just can't do it. So, you know, we've earned zero over the last 2 months.
Difficult.
So we've just put it out there to the team, all of them. Are you happy if and when we open to come back? And everyone is chomping at the bit. You know, again, we've got patients really keen to go. So the confidence is there from staff and clients.
Thanks, Geoff.
It's interesting, I think, with the financial variables that exist in and around private practice aren't always understood by those that aren't necessarily in it, or you know, if the circumstances that I now know of running it are different to what I understood of it when it was a room above a hairdresser's or on the side of a gym, or when you had your bed that you put into the corner of a leisure centre. It's a different circumstance, and these things are relevant and sometimes misunderstood. And so thanks, Geoff, for sharing the details, and some of those questions are brilliant. No doubt when Geoff does need to go, we'll be able to then sift through the comments, and if there's anything we can't answer that are for Geoff, then I'm sure he'll be able to pick those up after the fact. Now, Manful, I want to bring you in, Mike. You've particularly been thoughtful about your comments where, like me, you're interested not always in the outcome of what someone's thinking is, but also when they show their work when they think in public. It's obviously something that we've got a lot of kinship over and we work together on various projects with. Would you like to share your sort of take on the matter, as well as then passing comment, if you don't mind, on that? You know, what is it about the variables of what people's reasoning is that you feel is relevant to the ethics?
Yeah, absolutely. And I think everyone so far has covered the topic so well. I've been really fortunate through this whole experience that I was someone who, I only have a small clinical practice, as in the amount of my week that's dedicated to seeing clients. And a lot of that already existed online, and I've been able to easily transition, and in fact, probably grow my client base over the last 6 weeks. What that's allowed me to do is be relatively impartial whenever I've seen things, read things, and certainly when I've been speaking in my sports injury fix role. So I've been able to put my personal emotions and finances and business to one side to a point. And it's allowed me with an open mind to listen to the thought processes. I think everyone so far has been really succinct at saying how everyone's circumstances is different. And what the whole variety of thought processes has led me to the conclusion of is that fundamentally we're talking about two things. We're talking about risk and we're talking about confidence, which are obviously uniquely interlinked in this case. And the thing that's jumped off the page to me, which has to be put out on the table and has to be accepted by people, is that risk means different things to different people, and how you satisfy that risk to bring the confidence to yourself, your clinic, your patients, is the key thing. And what we can't do is use whatever levels of risk we need to satisfy our own needs and confidence to judge those of other people. We know that one of the beauties of the MSK profession is it's littered with so many different professions. How a soft tissue therapist, how a manual therapist will have to mitigate the risk and think about getting their business back up and running will be fundamentally different to someone, say, in my position as a clinician. So the systems and the things that we need to discuss and the topics that need to be covered are exactly what the people are talking about, is how do we mitigate risk? How do we satisfy ourselves and build confidence? And when we've got that in place, exactly as Paula said, switching the focus then, because this is the key thing of all this. Our professional background and our professional expertise will pretty much make it a very smooth transition for most of us to be able to put those risk assessments in place and mitigate the risk. Geoff has lovely walkthrough of how he's done it. We can see Geoff's confidence, that he's confident in his clinic and his team to reopen. But the fundamental thing as therapists we need to be talking about is how we're going to transmit that confidence to our patients. Because there's a societal thing that's gone on, and we know there's different attitudes across society, but generally my take is that society is scared. Society are fearful across the board of the coronavirus. And we really need to bring those patients in. We spend most of our time talking about including the patients and patient-centered care, and it's probably never been more relevant. We need to factor in building the confidence in whatever facets we need to for our business to get the patients back in the clinics as and when you're ready to open your clinics.
No, fantastic points. I think one of the things, just again, for those that are joining us, we are going to be trying to draw the people into this conversation. We've got people in the waiting room, so we will be coming to you shortly. Some really thoughtful comments on the comments section. Please do make us aware if you are wanting to join us and make those points in person. The details are all on the comments section for how to access the Zoom. You will end up in the waiting room and we'll draw you in and possibly even kick you out as we need to make sure it don't get too cluttered. So forgive us for having to play that role. So what I wanted to make sure I don't do is hide away from the fact that I do have a private practice and I've got skin in the game. I can't profess to be a moderator here without some thoughts on the matter. And so therefore, probably worth me just trying to, instead of reiterating all the great points that were already made, I do see one of the variables that I am reasoning with now that I was, that is different to the weeks gone by, is that I think we are in a different healthcare context and recognising the environment in the broader evidence as we see it, including some of the polling data that comes from people's public perception over and geographic and demographic differences in that population data about what people's perceptions are of lockdown and their fear. And one of the things that I want to mention is that the circumstances of rates of transmission and the severity to healthcare professionals, as well as to just the how dangerous the actual virus was. Now, I'm not suddenly going to play that down, and it'd be very clumsy of me to do so. But I am going to make note of the fact that, fortunately, as is the nature of progress, is that we have become better at understanding and better at managing the condition as time has passed. Doesn't mean there's room for complacency, but what I do think is that it's relevant that the London Nightingale Hospital, as one example, was a 4,000 bed ICU style military field hospital that was set up as as a means of stopping us being overwhelmed, like what happened in northern Italy in Lombardy. And it saw 56 patients, and therefore a massive success. And therefore, I'm not going to suggest that that's indication we can be complacent, but it's also relevant that the circumstances of which, when that was being built, we are in a different environment in which, when we think about the provisions that could be made to minimize and mitigate the potential transmission or the potential for harm, the ways in which private practice can step up and do a match, if not go in excess of what NHS institutions are able to do at the moment, in care homes certainly, means that that is a relevant variable for me. I'm not saying it's any sort of deal breaker. I'm constantly interested in reasoning with other variables, but I will admit that those sorts of factors do play a role in me working that out. And when certain industries are being floated to potentially be reopening or being encouraged to make sure you do crack on and work, manufacturing being an example of that for economic reasons, compared to food hygiene, as well as then construction being outdoor spaces and food hygiene being something that, of course, hygiene's of the highest order and inherent to it. Once you get into manufacturing and you're just doing some voluntary social distancing within workplaces in manufacturing, you're starting to reopen certain parts of the economy in which fundamentally I think that starts to then leave the door ajar for us to start to really think about the sensibilities of how we can get back to going and get back to practice, especially when that green light isn't going to come. So I just want to throw that out there. That's me making sure that I'm not seen to be holding opinions and not sharing them and spinning them into my questions. Enough from me, though. I want to throw it back out to you guys for any points on each other's points, and also you, Jem, as to whether or not we start to then bring in some comments and questions.
Yeah, I think the comments and the questions are actually coming through thick and fast, and there's some really good ones. I'm really sorry that I keep looking down. I'm trying to sort of moderate some of the comments that are coming through. What I might do is just run through a few, if that's all right, and then, you know, feel free to jump in. We just had one from Scott Gormley, who I think I might know. I'm not sure. Apologies if I do.
I know Scott, good lad.
What's your opinions on if the NHS go completely remote and stop all face-to-face and the guidance doesn't change from the CSP? I'd love to discuss this.
Is that
it's
very
out
topic we were going to stay off, and that's the method of practice?
Who knows? Just a thought. I think it's just thrown out there, but an interesting one. I think it's unlikely. I think from what I can gather from some conversations I've had with my work is that a lot of triage will stay remote. And I just wonder whether we were moving towards this anyway. Again, very random point, but, you know, this is maybe forwardly forced something that, you know, maybe the NHS, you know, thinking about the volume that they see and does in private practice, whether there may be an element of this, you know, remote consultation that actually will stay with us for some time. I appreciate not everybody will work like that, but I know that, you know, from a big corporation point of view and maybe from the NHS, you know, the amount of people you can screen remotely compared to how many appointments you need to make and the cost element of that is interesting, and I wonder whether we might keep elements of that. So I think to phase out into face-to-face again, I think a lot of organisations may look to do that, whether that be private sort of hospitals or setups, whether that be NHS screening services or, you know, private practices, whether you decide to, you know, do a triage consultation. And I think this is probably where I would go if I was practicing, you know, have that consultation online. Are they appropriate face-to-face? Do they want face-to-face? Can you manage it remotely? And then therefore, you know, provide them that pathway if they want, you know, the extra support, you know, hands-on or whatever. So yeah, that's my thought and half an answered question to Scott's, I think.
No, I think one of the interesting factors on that is always, why are they doing that? If that was what they did, is that because they have evidence that actually it's what they're declaring and it's officially declared by the NHS to be non-essential healthcare in such a way that they can't comprehend much in way of any urgency to getting back to that? And even though they're, you know, proper evaluation of the downstream effects of that, or are they saying that actually there's good evidence that it's actually it's a spreading intervention? You know, there's evidence that it's actually going to then perpetuate and worsen our circumstance societally, or there could be, and this is a variable that wouldn't apply to private practice really, is that are they doing that because they would rather a redeployment into domiciliary and community, and that they are deciding to move their workforce differently? If that's in the rationale, then it wouldn't influence us as much as the things I mentioned earlier. So it depends as to why they would do that. And also, yeah, as for you know, the CSP, I think they're in a situation where they inherently will find themselves needing to sit on the fence for legal reasons. Their constitution doesn't allow them to be more explicit than guidance. And you can leave the CSP tomorrow. It's a member organisation. It has no official governance or mandate for it's not a governing body as such.
Sorry. Sorry.
I was just going to throw one out there. A moderate size of our workload is kind of almost lifestyle treatment. So, you know, we're offering a service that you wouldn't necessarily receive in NHS. So if someone is prone to a bad back because they do a desk job and they can't change that, and we've rehabbed them and strengthened them, but they're just not coping with sitting, and that session a month or 2 months keeps them on the straight and narrow and pain-free. No different to an athlete who's training, who needs some regular soft tissue work or, you know, injury prevention strategies. You know, that group of people in private practice is probably a relatively large amount of what we see. And they will want hands-on. You know, we've seen a lot. I've done a lot of remote stuff, and with the, you know, advice from Mike over the past few weeks, it's been a great learning curve for us, and it's definitely something we're going to carry on with to enhance our service. But the number of people who said, I just can't wait till you open, because they just want that contact and that psychosocial approach to addressing everything. Psychology of injury for me is massive. And I believe I address the psychology of injury rather than just treat the injury. And if you can get that, I think it makes you very powerful in what you can give. It also makes you a very good salesperson, because that person will always want to come back to you because they trust you and they can understand the thought process of why you've done X, Y, and Z. So that element, I think, is part and parcel of private practice. And to lose that, I think you'll lose a fair whack of your private practice income.
I think it's a two-pronged from me as well, because if you work in any sports team that you're traveling with and you don't do hands-on, you won't be lasting very long at all. You'll be out the door in a second. The other thing about the NHS is obviously also two-pronged, because if you're coming out of surgery, they're not going to be able to remotely look after you, because there is hospital-based physio that then gets transferred to the outpatients physio, and then they go off, and then they could be managed remotely, I guess. But certainly hands-on, the situation I had a conversation with Mike yesterday about hands-on therapy. I do a lot of manual therapy. We talked about the fact that, you know, we don't want people to be therapy dependent. We want people to be, or therapist dependent, should we? So we've got a responsibility to make sure that we are educating these people as well. But personally, you know, I do still do a lot of manual therapy because it works for me and for the people that I see, and I get good results. So it's going to be, you know, it's very, very difficult to go to remote completely, but I'm certainly learned some things along the way. I am doing more video consultations, but I love what you've just said, Geoff. I think it's a great idea to do the initial consultation online, and then if you deem that they need to come in for something else, then that can be triaged in that way. So yeah, so you know, there's a few learning curves, but as far as the NHS going completely remotely, I can't see that happening, because there's too much stuff going on in hospital. There's too many things that physios have to look at on site, and then they will be transitioned down into outpatients and then out. So, and you need people there for that.
Can I check something in just on the going on the remote stuff and liability and all that stuff? Is that there are some things that remote you can't test. You know, you can't test Babinski, you can't test certain things, and that opens up a can of worms. When Physio Direct first came in, and this was, God, 18 years ago, I think, and you know, I'd sit on the phone and, you know, I felt like I was doing a good job, but actually, I felt now that actually I was missing some things. You know, you can differentially diagnose, absolutely, but it's not as good as hands-on. You know, you have to take that element of, okay, if we're talking about liability, are you missing something with a remote? Is there something you can miss? Absolutely. You know, you're not going to see people walking down the car park to your clinic, which a guy not long ago, he'd had a stroke but didn't know it, and he came with shoulder pain, but he staggered down the road. And the first thing I thought was, oh, I know what's going on. There's loads of factors that you don't get remotely, and as much as it's a great service, for me, it's just not as good as face to face.
I think as
And
well.
I think, sorry, I'll just as somebody that obviously works in that sort of environment at the moment, and there has been, a little bit of conversation on the group about, the influence of insurance companies at the moment, and to reassure a lot of people, a lot of physios like myself who work, within this environment and work for PMI companies, we are physios, like yourselves. We understand exactly as Geoff said, and I am a very manual therapist as well, and always have been. I come from a sports background. But I also now see both sides, and I love my triage role because I can see it. I can see what they think, and I love, putting the patient on a journey and a pathway. And if they need, acute urgent care, I feel I can screen for that and send them, to somebody like Jonathon or, an MS or for a physician setting, or I can give self exercises if it is something fairly straightforward. But I also appreciate and get on the phone that people want to see people face to face. People love the relationships that they build with their clinics, and I know that I am, and a lot of all the people that I work with are still trying to now get that back on board. We are not trying to just refer into our own insurance company. The profession wouldn't work if we only did that. It is important that we remember this, and I want to put that across because it has come up a few times. We understand the value of like Geoff said, assessment and face-to-face and contact, and it is always going to have a place as far as I'm concerned. So
I think one of the things that I want to make sure I mention is that I don't disagree necessarily with, especially the assessment variables that have been described as to what could be missed. It's also one of the criteria. If you've got someone that you're bodging a neuro assessment and you sort of something doesn't sit right, your clinical hunch alarms are going off, and you really do want to know what their Babinski says or how much they can resist a specific myotomal test, and that's the sort of thing we should have been seeing. And fundamentally, the way that private practice had to be closed down means that circumstances surrounding that have been challenging for people to see that and to triage it effectively. But I can admit that although I don't see a massive clinical caseload these days within our practice, I would say our practice probably does what we consider traditional manual therapy about 15% of the time. Me personally, that's probably more like 5 or 10. It's not a core part of my practice. And as I said, no need to get into the weeds on why. However, our care model is incredibly involved and therefore actually very difficult for us to simulate virtually. The way that we then, instead of laying hands as a means of pain relief, we do a very involved exposure-based care model where we're in the gym a majority of the time, both for assessment and for treatment, doing very much guided exposure-based lifting of weights and exploring movement and doing a really guided rehabilitation approach where you scale someone's function and be creative around what they're doing with their bodies, which is something that is very challenging to simulate, especially because one of the ways in which we've brought that forward is to having moved away from a hands-on approach of pain relief by mechanism of delivery through passive or collaborative care. And so it's been interesting for us to recognise just how involved our delivery of care is, even though it's not typically hands-on of a sort. It's hands-on in a sense that I've got my hand on someone's shoulder, encouraging them to do to flex their spine as they lift something up. So it's worth mentioning that fundamentally the uptake, even in practices like mine that are very much rehab-centric, has still been a huge challenge, not just in terms of clinical delivery, but the actual economics of it, of course, as well.
Yeah, agreed. I mean, when I get athletes in, I have to be able to see them lift. And so I've got a clinic in a gym and I'm in the gym with them, watching what they're doing to see what's going wrong. And I have to be with them. So like you said, you're looking at movement patterns, et cetera, et cetera. So it's very difficult to do that. I can manage some athletes from afar, but it's very difficult. I'd much rather be there to be able to see what they're doing and have an input then. So.
Should we get, here we are, perfect timing.
Yeah, I thought we'd accept Matthew Scarsbrook, friend of mine and Mike's here, who we were talking about manual therapy. I'm a sports massage therapist, but certainly one of a biopsychosocial flavour who recognises its position within the wider holistic care of patients, but certainly someone that can probably speak to some of these variables directly. So great to get you on, Matt. Hopefully you can hear us. He's just connecting his audio, it's telling me. But do let us know once you're on there, Matt, because it'd be great to hear from you and how you feel that these issues affect you. He commented in the Facebook chat and definitely we'll really hope he can join us.
Jack, we've surveyed the patients we've done. We've done 200-300 remote consultations, and I surveyed the patients depending on the different type of consult that they were having. And, you know, for an MRI follow-up, invariably patients said, yeah, that worked. And I also asked them, and was it acceptable to you because of the situation, or would it have also been acceptable without the COVID lockdown? And not surprising, MRI, you know, thumbs up. They said, yeah, very useful, and I would have happily done that at any time in the future. But there was a more mixed pattern on first-time assessments. You know, everybody, bar 2 patients out of the first, we've got 60 responses. The bar 2 patients, they've said it was either very worthwhile or worthwhile. But of the new consults, many of them said, but it was really only acceptable because of the situation we find ourselves in. And you know, I've done some pretty long clinics on Zoom and on the phone, and they're soul destroying. They're hard work.
No, it's a very different circumstance. Hopefully, Matthew, you can hear us, and we can hear you, if possible.
Yes. Apologies. I think I was watching through Facebook. I think it was a bit of a delay. I'm just going to move somewhere where you can see me, hopefully. No, we'll go for that one. Right, that'll do. Yes, thank you. Yeah, so I might have missed the last bit was being talked about, so apologies if I sound like I'm talking in the past. But I think the original sort of question I posted in the group was noting that there wasn't anyone representing, I suppose, pure manual therapists. Now, obviously, I appreciate that actually. Well, I know Paula is very manual as well, and obviously listen to Jem and to Geoff as well. Manual therapy is a key part of what they provide, but it is under the umbrella of being physiotherapists, which does allow for a certain level of, I suppose, greater scope when online, when working online with someone. Certainly, being able to provide some form of rehabilitation advice over the web. And as a soft tissue therapist, that is something that I've been able to also benefit from, and that's what I'm working with my clients online. But I was just wondering, to borrow from one of Matt Phillips' comments earlier about echo chambers. Obviously, within this community, and certainly the community that Jem's put together, whilst there are differing views, generally, I think we're all on the same page that we need to do things safely for clients. But I'm just wondering how we would roll that out and influence groups who represent therapists who are perhaps purely manual. So, you know, your pure sports massage therapist who isn't qualified to provide sort of rehabilitation advice, and so as a result at the moment has entirely shut down and has no income, and maybe at a point where they're feeling incredible pressure, either financially or driven perhaps by clinic owners for whom they work, to go back to work. You know, in the same way that hairdressers are apparently, you know, there's a black market for hairdressers at the moment, and you can go around their house and have a haircut. I'm wondering how this kind of discussion, this kind of community can reach out to that, what I suspect is probably a larger number of therapists who absolutely cannot do any work without being hands-on and being face-to-face with their client. And perhaps we run the risk, as being pragmatic as we are, if they go to work in a way that doesn't fit in with the evidence base and doesn't fit in with the care and attention that we might take, there might be a lot more of them. And so actually it might mean that all of the PPE we wear might be for now.
I put you in the same umbrella as ourselves, because we've got 3 sports therapists in our team, and we're treating them the same. So I don't think it matters if you've got hands-on for 5 minutes or 30 minutes. If you're going to do that practice, then I think everyone does the same protocol. And so again, within our team, if and when we do open, we'll offer those services because those guys are doing the same techniques as we are, but they're just doing it maybe longer, but they'll have exactly the same PP. I think the risk there is the same. I don't think there's any more or any less risk depending on the time. I think it's just, you know, the patient's head down on a couch, well, actually, that's probably a pretty safe place to be.
Yeah, no, I suppose I was more considering as well, sort of the therapists who are sort of standalone, perhaps working from home. They have you know, they utilise their spare bedroom.
Yeah.
I mean,
there's a huge number of those clients out there.
I think I'd like to offer some assurances and some advice to some people out there that may not have even tried doing some video consultations, because even as a sports massage practitioner, a soft tissue therapist, or a physio that does lots of manual therapy, there are so many things that you can transfer onto, if people are in couples, you could potentially teach the partner to do certain things online. There's certainly lots of things we can do with, you know, massage sticks and, you know, massage type balls, or even onions I've used. I've said to somebody, go grab an onion because they haven't got a ball. And I've been able to coach people through almost self-treatment and rehab after assessing them, and it's worked incredibly well. I've had a couple where I was really directing the guy how to, you know, mobilize her shoulder, and her pain dropped from 8 to 2, so they're able to continue to do that, but with the correct advice as to how often, and directed by the patient, fortunately, who's already had that treatment, so understands what it should feel like. So there's an awful lot of soft tissue therapists out there that have the skills and should be able to describe exactly what they want somebody else to do. So the reassurance is there that there is potentially a model for those people that they could actually attempt should this situation go on for longer, and they are working in their own homes and they're concerned about, you know, contamination, etc., etc. Maybe it's time to try with the people that they've already got to try and do some guided soft tissue therapy, because I think that there's definitely there's a market out there for it, and I do think that people would be incredibly respectful that their therapist is trying to help them in some way. So I think it's worth a try. I think it's definitely worth it.
From a soft tissue therapy.
Sorry to interrupt. We've got a comment from Gerard Green saying one of the main reasons uptake is poor is that until 7 weeks ago it rarely existed. This was virtual consulting, and we're trying to market something that's new for us. It'll take time. It'll be new for patients. This is, I think, I do very much agree with that, in that we need to bear in mind, and this is why I've been finding it really interesting to speak to people like Katie Napton, who's also appearing and commenting in the chat, and will be speaking at Therapy Live, by the way, so you definitely want to be checking her out. But she's been doing a virtual consultations for 3 years, virtual clinic for 3 years, and so that's been really useful, that she's not someone that's just adapted and flexed like many of us have in the recent times. So she's got a real level of expertise in that. But it's also worth bearing in mind that the uptake and the utility of it and the versatility of it, as you've just described really well there, Paula, is something that we can't. It's unfair for that to be the final analysis within 6 or 7 weeks, isn't it? We need to make sure we recognise that the broader aspects of it and how we are marketing a new product, as Gerard says, but also how it's being received by patients.
Yeah.
Very much so, and you know, I completely agree with you, Paula, in terms of soft tissue therapy. I suppose I'm thinking primarily, I can't think of a way of phrasing it, but sort of level 3 type massage therapists as opposed to sort of level 5, and the fact that there are probably a greater number of level 3 massage therapists, but also other holistic type therapists for whom face-to-face is a fundamental part of their practice. That's sort of where I meant, as opposed to soft tissue.
Yeah. Okay. Yeah. So they'll be, I mean, with all due respect as well, but they're the same, that, like you say, there's different groups, isn't there? There's a beauty therapist type massage, there's the holistic type massage, and then you've got the ones that are level 3, but they're doing sports massage under guidance of somebody else. So yeah, it's there's still things, like you've said, you've touched on the personal nature of the relationships they have with people, so there's still things that they could be discussing with regards to the biopsychosocial side of things. They will know that these patients, so they could check in with them at least and just keep those patients going in a way that makes them know that they're being thought about, so that when they are able to come back to practice, it's not like they're suddenly popping out the blue going, when do you want an appointment? They've kind of continued to coddle the people, I guess, in some ways.
It's It's great. I mean, thanks for your comments. I'm just I just want to mention something that's come up on the group a little bit about insurance and liability, and I think it covers all bases. You know, whether you are any type of therapist, chiro, osteo, physio, sports massage, sports therapist. I think Jonathan, I'd like to we spoke a few days ago, and you mentioned something about a lovely comment about if you were questioned by the GMC. You know, if the GMC, for example, in your case, turned around to you in a year's time and said, you know, you were wrong. I don't think you should have opened at that point. What are your thoughts? And we had a really nice chat, so I wondered if you'd like to sort of just comment on that scenario that we discussed.
Yeah, I mean, forgive me for repeating a little bit of what I said, just for those who may have joined a little bit late. But at the moment, there are no people who are experts in COVID-19 and handling it from the clinician's point of view. And those that are experts have got about 6 weeks experience. And so we don't have anything else to draw on. We can't draw on how we manage influenza. We can't draw on the last pandemic that we had. And when, if you're taken to task for what you're doing, i.e. opening your practice, then the likelihood is because these organizations tend to use their experts to look at what's gone before, they'll slip into the trap of assuming that what you knew back then was what they now know 18 months down the line. And the problem is there's no knowledge, there's no guidance, there's a leadership vacuum. All the organizations that we thought or were telling us that they were leading us and turned out actually they're not leading us. And I think that we've got to make decisions that are based on common sense. I agree fully with Geoff saying there's no point driving the clinic off a cliff. You don't open 5 days on week one. You may open, we're going to open maybe just one morning for face-to-face. And who can come around and say that we were wrong to do it? There's no guidance. So as long as you're not doing something overtly stupid, I don't see that there's an issue from a litigation point of view.
Would you say that face-to-face is inadvertently stupid at this present time? I'd be interested to know your thoughts on that. No,
we have a plan that we will relax our rules on face-to-face next week, and I don't think we're going to have a queue out the door. But what we will do is where we think that there is where we think that the consultation would be better face-to-face, we will ask the patient if they want it face-to-face, and we have our measures to put in place, which will no doubt be very similar to yours. And up until now, we've insisted on a triage online consultation, remote consultation, before anyone has a face-to-face consult. And I've done about 3 in the last 6 weeks for various reasons. And one was an anxious patient who's just quite tricky to manage, and I just knew it was going to be better face-to-face. So we both, wore face masks, and that went fine. But it's, you're not. I can't see that there's going to be a lot of mud slung at people who've opened, and unless they've done something which is really, I don't know, unethical or immoral or something that's upset everybody for other reasons. But opening your clinic isn't a big issue as far as I'm concerned, if you're being sensible about it.
I think it comes down to as well, we are, Paul and I discussed this today, we are autonomous practitioners. Yes, this is a hugely different environment and on a global scale that we have to be incredibly careful about, from an infection control point of view. But we are, in a broad sense, very good at our job. Whatever you do, if you're passionate and you're caring and you're frustrated, as a lot of people are, it means that you're good and you're thinking and you're self-aware. Whatever your stance is at the moment, whether you decide to sort of bring in moderate sort of phase return to practice this week and next, or actually you're not thinking of opening for 2 weeks, that's fine, because you're working within the realms of your own autonomous practice. And I think one of the reasons we wanted to do this, as I said today, was that actually, people are having to start to make these decisions. And I think you have to trust your own ability to risk assess as you would do with any patient that walks through your door and any, you know, acute scenario that you may find yourself. And I think it's almost backing yourself to make that decision and stand up and say, yes, I considered all the evidence. I know what you know, my risks are, you know, and I'm prepared to take that. And how can I start to develop moving forward? So I just want to, say, to bring in something
to jump on that. I mean, I think, you know, there's only one thing you need to do to become successful in private practice in orthopedics, and that's spend the last 20 years obsessively managing your reputation. And that's all you have to do. You don't have to do anything else to be successful, because if you do that right, then it works. But when you think about what it requires to manage your reputation, these are the issues that crop up, maybe not quite as serious as this one. But if you're managing your reputation, you're not going to be making foolish movements in the next few weeks.
Yeah, I just have a thanks there, Jonathan. I just have a question from somebody that posted on the group. I don't have a name, I have the clinic name. It's called Go Physio. I think they've been looking at a few of these chats, so we're quite interested in this one this evening. And one of the things they said would be helpful would be trying to make an educated calculation of our expected caseload once we're reopened, i.e. start at 15% and how we anticipate to build from there. And I think, you know, it comes with managing staff and expectation. I think that's very difficult to answer, obviously, at the moment, but I'd be interested in your thoughts on, you know, your own thoughts on how you think we could maybe go about this in a, you know, strategic, phased approach to the situation.
Well, we've about 90% at one stage.
Okay.
And we're now up to about 20-25%. And that's remote.
So do you think it's much, like you said, do you think it's about just getting the message out at the moment and seeing what the uptake it is per practice? I think it's very difficult. I think if I was in that situation, I think it would be difficult to plan that, you know, percentage wise. I think just to see how it would evolve.
Sorry, I had a bit of a delay there, Jem. I didn't mean to interrupt. I'm a bit nervy about that. I think it's going to be slow going. If you think about, especially the way in which we've conditioned our because of the model of care that I've just described. I know I said I won't get into the weeds too much on it, but it just seemed relevant to this, is that we've had a number of patients that have then said, well, maybe this is the time for me to suck it and see and go for this self-management approach. You've been seeing me monthly, then 6 weekly, etc. So sod it, cut the cord. And so they've done that a bit sooner than maybe they would otherwise have done. And we typically, the thing with us is that we have it's front loaded. We only see patients sort of on average 3.5 times. We front loaded in terms of the economics of that as well. It's a more expensive initial assessment, and we base it on probably seeing more initial assessments that most practices would be able to fit in, because we're not seeing loads of follow-ups. And therefore, patients that are returners or recommendations and things like that, when they think about the model of care, it's their evaluation of what is urgent. So if we open next week and they perceive that their care needs are things that they can put off a few more weeks, or that they can potentially interface with something virtually and stuff, that's really important as well. It's not just our assessment of their urgency, it's theirs too. And so I think that's one thing I'm concerned about. I think it's going to be really slow, but because it's going to be slow, it almost makes me feel like with the right provisions, that's one of the reasons why we do need to get going. Otherwise, there's mouths to feed really, and this isn't health versus wealth, it's lives versus lives really. That's a really narrow and an ignorant take on economics. If you think
and the economy
completely crush the economy and people won't cost lives, then they don't know economics.
And it's balancing the economy and the building and the phasing now, which is what we, you know, hopefully we don't know what's going to happen tomorrow evening. You know, it's been built up all week, but, you know, whatever he says, you know, they've got an incredibly tough job, these powers that be, about balancing, you know, getting this country back into track. And healthcare is a huge part of that. And I think we've just had a comment from Tim Liggett saying, you know, he is confused about the discussions that we're having about people opening, when at the moment the emergency face-to-face appointments are only happening, you know, and there hasn't been any other guidance. You know, do the guidelines that are applying to the NHS in terms of only face-to-face not apply to private practitioners? I think my answer to that, Tim, is that, you know, we're not saying at the moment, yes, you know, we're going to get the green light, and so, you know, blue and green light that everyone can open from Monday. We're not saying that. I think we're just trying to discuss options of maybe decisions that need to be made moving forwards, and how and why people are having to start doing this now as opposed to before, because things are progressing and they are improving. And whether you're a hairdresser or a takeaway or a pub owner or whatever, these decisions are going to have to come into play. And we are essentially no different. As Jack said, we all have a livelihood and a part to play in the economy. So that's
I think Ian's point there as well is. Oh, sorry, Matt. I've done it again.
No, you
sorry,
carry on. I'm going to jump in on you next time. No,
you don't. Sorry, mate. Yeah, I've got this delay. I'm being even ruder than usual. Just on Ian's point, I don't know, Ian, if you were tuning in earlier when I mentioned about the fact that it's why the NHS is making changes or doing what they're doing that matters to me rather than what they're actually doing. Especially the way in which they've behaved recently is because of the ability for them to redeploy into acute services and thinking that they needed to bolster. We needed to use MSK personnel as porters in military hospitals of 4,000 beds, right? That's the circumstances around why they are doing what they're doing with regards to levels of urgency don't necessarily apply as cleanly as we might like. If it was that it was purely because of clinical need, hygiene, the virility, the epidemiology, if that was the pure argument for why they were behaving, then we'd be able to use that as a perfect transposable argument. But at the moment, I don't see it because that's more complex reasons as to why they're behaving as they are. Sorry, Matt.
No, it's all good. No, so I suppose I was going to ask, in terms of the discussions about, hypothetically opening next week. Now, is that in part because certain areas of MSK, so physios, for example, never actually had to fully close? Pretty much everyone as part of this discussion closed, I think, more from a moral perspective than an actual legal requirement, because, of course, emergency, whatever that means, and I'll come to that in a second, emergency appointments were still okay. And as a result, when we're talking about the different areas of the economy opening, actually, if you're a physiotherapist, it is much more an autonomous decision. I think if you are, and the same goes, I suspect, for osteo and for chiro as well, if you are more a massage therapist, actually the autonomy, I think, is largely taken away. And because there are, quite frankly, no circumstances, I believe, under which I could claim that anything I provide is emergency, is urgent care. And also, to that extent, we probably fit into the same sort of mold as your hairdressers, your tattoo parlors, very, very close contact industries who are a bit of a luxury, to be perfectly honest. Although I must admit, I really did enjoy that comment, Jack, about this idea of emergency, and actually it's not necessarily just our perception of urgent care, but actually our clients as well, and there's obviously been all sorts of stories and messages over Facebook in particular about, such and such therapist has opened and I know they're providing treatments, and the comeback is because my client was in absolute agony, they were in complete tears and they just had to see me. And I get really torn now that you've mentioned, the sort of the client's urgency, because I would say, as a massage therapist, again, there's nothing that urgent that I should see, and if it is that bad, I would refer to a physiotherapist who I knew was open and able to deal with it. But alternatively, if you're looking at the psychology of the situation, if you're looking at the fact that the client has in their perception, an urgent requirement to see you as a therapist, I think it does actually make it a little bit more pressured as a therapist to know quite what to do.
I'd love Mike's opinion on that as well. Mike, you've got an eye on a variety of different professionals and professions better than anyone I know. I'd love your thoughts on how it affects different professions and therapies differently.
Yeah, I think like Matt hit some great points there, and the points that we've chatted about before, Matt and I, and certainly within Sports Injury Fix Network. It's the same conversation that we have about what treatment techniques you prefer to use, how you prefer to run your clinical practice, that everyone's coming at it from a different standpoint and a different viewpoint. I think and it's me saying what I always say on this matter, in some ways, there are people regardless of your background, who practice a certain way. And we could be as bold as to call them the good therapists. And we have some who will practice for other reasons in other ways. And I don't think it's a question that can be answered with how certain professions would react. It's how individual professionals within groups of ability and ethics and morals, and they're just the moral compass almost. That's how people will react in the two groups. Are certain therapists, certain professions coming from it a different angle? Yes, some are, but certainly also if we say that the hands-on, the soft tissue therapists that we deal with, I see a real reluctance from these guys to go back within the Sports Injury Fix Network. So I'm still sitting on the fence slightly in I think it's good or bad. Therapists will make the right or wrong decisions rather than certain professional backgrounds influencing a more wider group-based decision.
Yeah, I think that's a really interesting point. And I think the way in which I look at it in terms of the utopian MSK industry that I continue to endeavour to build through MSK reform and various other things is a different world and a different landscape in which people's perception, we've managed to translate a perception of what urgent means to the public on a wider level. However, my point necessarily about patients' sense of urgency isn't necessarily their sense of needing and wanting our particular flavour of pain relief. And fundamentally, that is why styles of practice is something I didn't want to get into the weeds on, is because I do see a lot of the techniques as being a flavour of pain relief, and little more than that in terms of its mechanistic properties. But I think what I'm getting at with urgency is that patients may well have made a massive difference to the weeks that have just happened if they came to see us, even if it was for a thorough neuro assessment and appropriate reassurance that came from that assessment. And it's a challenging thing. And so that is why it needs to be a symbiotic relationship, I think, between therapist and patient, especially those that we know well, or those families, or those recommendations that we know well. And it becomes naturally very messy. And I think the way in which it interfaces between professions is messier than say physio, even osteo, chiro. But I think I was really bothered about looking at hairdressers. It was just an obvious thing that people were going to be talking about. So I was really interested. When the hairdressers open was going to be the more obvious one. When I was thinking about epidemiology and the spread of the virus, it was a different landscape. When it looked different in terms of what the evidence and what we knew of the disease, I thought that was going to be a really relevant moment. It matters less to me now because of the circumstances changing. And I think that we need to be more mature, and we're not going to get something like that. Unfortunately, Matt, you may well need to. You might be somewhere nearer that compared to us. But I'd say for physios, I think that would be risk averse to the point of regret if we went down that route.
And I agree. And I think, in terms of making the assumption that someone like a hairdresser is going to be, by whatever government decision, delayed for a significant longer period of time until they are confident to sort of allow that kind of practice. It makes me sort of question as a predominantly massage therapist whether actually the concern about PPE will even be relevant at that point. Because to be optimistic, I would hope that actually by the time we get there, that actually PPE will be far less of an issue because we understand it. We've got it, track and trace is up and running, and all the other measures that we're being told are coming in order to help sort of mitigate a second peak would mean that that's not required. The pessimistic side of me says that actually, I think well before that, we're going to know if we're going to have a second peak, and therefore there might be another delay to that kind of practice opening. But yeah, I think we will, as massage therapists, I think we will be slightly further down the queue.
I think, I'm just a little bit conscious of time and just, there's some great chat, and it's obviously something I think we can probably pick up and carry on. Jack, I think you agree this is, we can take some themes away from this and obviously see how we evolve. Hopefully, if you're all in agreement, just to close, I just want to mention a couple of things. People have mentioned a few comments about insurance, and obviously their CSP stance on, you know, whether they're protected if they open, and obviously giving viewpoints about whether they think it's effective or not. I think the answer to that question is we just don't know. I think there is an element now where we've come to in this discussion where we do need to now wait. You know, we need to see how things change over maybe the next sort of 14 days or so, and what guidance that we do get. We know that the CSP and Physio First are working on some guidance. We hope that that's going to be sort of useful for people in the private practice and across the sector. They have got an incredibly hard job to do to match everybody's needs, but we would hope that they would be able to do that. So I do think we've come to a point where, you know, some of the questions in terms of liability will be answered obviously in the next 10 days. And all I would say is if you have got direct questions about that, you must get in touch with the CSP. You know, that's what they're there for. You know, get whatever your governing body is. Sorry, I'm speaking as a physio, but they will be able to answer those questions. And if you have that email in yourself, then, you know, be proactive, you know, ask the question. If you don't get it, you know, contact different network groups that you've got and see if we can help. But there is only so much we are going to be able to answer in a short period of time. This is going to be a phased approach. There's a final comment, I think, from Gerard Green here. Nothing will change this week. Realistically, maybe July. Even then, take patients time to return, and we all need to be naturally optimistic. And I think we do. I think whatever your take on the situation is, you have to be autonomous, make your own decisions, manage your own risk, and let's keep supporting each other, and let's keep, you know, feeding information and resources in this time, which, you know, none of us thought we would be in as a profession at all. So
just to shout out quickly on the governing body side, I know particularly the ISRM and the STA, and obviously with Paula and the SMA, I know that they are working closely together in order to provide guidance to that area of the industry as well. Working under the same issue of they know what we know at this point, but they will be providing guidance. So I think Monday, for anyone in those professions, Monday's the time to be watching emails again for the latest updates.
Yeah, it's going to be interesting what comes out on Monday, and this is something that does sound like it's worthy of a recurrent conversation. I think one thing on the sort of the flow of it that's been mentioned and keeps coming up on the comments is that this is always a moving picture, and it is messy. There is a huge spectrum of opinion on this from those that consider that there should be a firing squad that anyone considers opening in 2020, through to people having not changed and made adjustments to practice. I feel like I can answer, as far as I know, to the insurance question with regards to the fact that if you think about the CSP's insurance, to be specific to that, it's through Greybrooks and underwritten by Aviva, and they are, well, certainly their practice insurance, but fundamentally the way in which the CSPs, obviously their insurance has been covering people in various different ways through the NHS at a difficult time, and it's based on your sensible professional risk assessment and through you adhering to the guidance that you are provided by your governing body under the HCPC, and the insurers aren't qualified to quibble that. Therefore, us starting back up through Geoff, actually, he's contacted Greybrooks, who are completely comfortable with him in his risk assessment as an autonomous practitioner, to have then be insured under what he's doing. And bear in mind, for those that are concerned about going about things uninsured, we've been all in touch with our insurers and been told that we shouldn't have closed. So don't be worried about us doing anything uninsured. They're not paying out on business interruption because the government didn't mandate it. So we never got a red light. So there's not a green light coming from insurers. It's just a continuation from them. So, you know, there's nothing going to be clumsy in that direction. Always be seeking advice, recognizing that guidance is not mandated, and that be, as is the ethos of this group, and why I'm very proud to have been even tentatively involved by Jemma. It's such an important thing that we find a way to support each other, recognise and be charitable when there's something that we disagree with, try and make progress, be solution focused, and try and work through this together. But thank you so much for you guys, as well as everyone on the comments, for this. I'm sure we'll speak again and hopefully see each other for a drink one day when this is all dusted down.
Thank you very much, everyone. Thanks.
Thank you.
Bye.
Thank you. Take care.
Bye.